Probably the biggest impact on these new treatments, so-called DAAs for hepatitis C, will be in the management of hepatitis C. These are drugs that specifically target proteins that are critical for replication of the hepatitis C virus that have been approved by the Food and Drug Administration within the last 3 to 4 years. And these drugs target the protease or the polymerase or the replication complex protein NS5A. And when used in combination, these drugs have a cure rate of well over 90%. So for the most common genotypes of hepatitis C in the United States, genotypes 1, 2, and 3, it's anticipated that one should be able to theoretically cure over 95% of individuals who are chronically infected with hepatitis C.
DAAs have changed everything about hepatitis C, revolutionized everything. Before, we were nervous to treat patients because our treatment with interferon was so serious, it had so many side effects that many of our patients, we would make them more ill. Now that we have all oral therapy without interferon, we can cure the majority of patients regardless of their underlying liver disease. So now we don't have to be afraid of hepatitis C patients anymore, whether they have kidney disease, whether they're pre-transplant, post-transplant, HIV, autoimmune disease. Those are no longer issues for us with the DAAs. It has revolutionized in the entire spectrum of who we treat and how we treat.
In contrast with previously approved treatments, these treatments have the advantage that, number one, they're more robust in terms of the sustained virological response, but in addition, they have very few adverse side effects, very few drug-drug interactions, and the courses of therapy, which used to be up to 48 weeks in length, are now down to 12 to 24 weeks in length, and thus it's highly acceptable to a broader population of infected individuals.
If I saw a patient in the past who had schizophrenia, cirrhosis, and was on dialysis, I wouldn't even necessarily have screened that patient for hepatitis C. I wouldn't have obtained their genotype because it didn't matter. They were never going to be treatment candidates with the therapies that I had available. But now the sky's the limit. I haven't met a single patient that I couldn't see the potential of therapy and to have the honest discussion of the risks and benefits and the reality of cure.
The critical thing in diagnosis is understanding the genotype, because currently approved medications are really effective with these cure rates in genotypes 1, 2, and 3. And there's a small proportion of individuals, perhaps up to 5% in the United States, who are infected with less common genotypes 4, 5, and 6, for which these treatments are not currently approved.
The patient studies early on with DAAs were so small. We were looking at patient panels of 15 or 20 patients, and we were seeing 97 to 100% cure rates. And we had never seen that in the world of Hep C. So when we saw the 85, 95, and 100% cure rate, we were very skeptical. Was that going to transition to the real world? And now that the DAAs have been out for over a year and a half, we see it.